Hello everyone. Welcome to the faculty interviews of ISOT 2023. As you are all aware, the National Conference of the Indian Society of Organ Transplantation 2023 is going to happen from 5th to 8th of October in the city of Kolkata. And here we have the series of faculty interviews where we have a candid chat with our esteemed faculty of the conference. And today we have the honor of talking to the lovely Dr. Phyllis August, who actually needs no introduction. She is a very well-renowned figure in the field of hypertension and obstetric nephrology. She actually completed her graduation from the prestigious Harvard University and the Yale School of Medicine, and is currently appointed as the Professor of Medicine and Professor of Obs and Gynecology in Medicine at the New York Presbyterian Weill Cornell Hospital. She is also the Program Director for Nephrology Fellowship in the Division of Nephrology and Hypertension at that institute. She is also the Director of Lange Center for Research and Education at the New York Presbyterian and Queens Center. She has done a vast amount of work on hypertension and kidney disease, hypertension and pregnancy-related kidney diseases. It's a complete pleasure to have you, madam, here with us today.
Thank you for inviting me. It's a pleasure to be speaking to you and to be in India for this meeting.
Thank you, ma'am. As I was going through the amazing amount of work you have done on hypertension and kidney diseases, I was intrigued to know that what exactly made you interested in this particular topic out of everything else in nephrology?
Well, it was kind of by accident, I think. I mean, I've always been very interested in nephrology. I think nephrology is a really great field. I became interested in medical school. I thought the physiology was so interesting. And then when I was a resident, I got introduced to transplant nephrology at Cornell because they were doing a lot of kidney transplants even then. And during my fellowship, though, we had to do a research project, and somebody in the hypertension center was interested in studying calcium metabolism in pregnancy, and then actually Dr. Sudhantharan was studying immunology, and we thought we would. I was doing some research projects as a fellow, both in calcium metabolism and hypertension in pregnancy, and also the immunology of preeclampsia. And so I started working with the obstetricians and making rounds with them. I had never really known much about preeclampsia as a medical resident. I trained in internal medicine, but in my fellowship, there was a really excellent maternal fetal medicine faculty person who we worked with. And so it was obviously a very fascinating area of nephrology and medicine in general. You know, you have the kidney, which is always interesting. You have a disease of the placenta, which is almost as interesting and as complex as the kidney, but much more difficult to really understand because it's hard to access the human placenta. But it really has everything. I mean, it's got the intellectual challenges of studying something that we don't really fully understand. It's so so many people in the world get pregnant, and so there's a lot of hypertension and kidney problems related to pregnancy, and it was a way of working in women's health that, you know, was just tied together a lot of things that I was interested in starting in medical school. And, you know, the opportunity to work with young, healthy women who then get very sick and who need a lot of support. And then to see, you know, if they're healthy enough to get pregnant, then they usually have a baby. And so you get to see babies a lot, but you don't have to take care of them. And so it's a kind of a challenging but happy field. You know, the outcomes, as difficult as they can be, are usually good. And women really appreciate it's so stressful having health issues when you're pregnant. And so women are really grateful to be able to have more expertise and help from other subspecialties when they're pregnant. Because sometimes if they're left solely in the hands of their obstetricians and they have a complex medical issue, it's scary.
That is so true, and it's especially true for our country where there is a huge unmet need of obstetric nephrology. And that actually takes me to the next question. The way you told that it is challenging, it is interesting, and it gives a complete satisfaction of treating a young patient who otherwise was doing fine and then has a catastrophic event during pregnancy. And usually it might also there's a possibility of a very good outcome. So that actually takes me to my next question, that in ISOT 2023 you will be talking about successful pregnancy post transplantation, and that is one of the most challenging thing which we come across, that those 9 months we have to take care of the mom's kidney and the baby also. So
Right.
what all things you feel that especially from a lower middle income country or a lower resource setting perspective, what all things we should be looking forward in your talk?
Well, I think it's really important to talk about pregnancy with young women even before they get the transplant. If they're having if they're having a planned transplant, and if they have a donor and it's all planned in advance, then I think that they have to know if that, first of all, they shouldn't get pregnant right away. They should wait at least a year. And even if they have a deceased donor transplant, you still have the opportunity, right after the transplant, to tell them, to make sure they understand that they should not get pregnant right away. It's not a good idea. The first 6 months to a year, as you well know, you're adjusting the immunosuppression, you're waiting to see how good the allograft is going to function, what's the baseline creatinine, proteinuria, some of the early infections like CMV will be taken care of and addressed, urinary tract infection. So you have all of that in the past, hopefully. And then by the end of the first year, you can say, okay, your creatinine is 1, your blood pressure is either, normal without medication or maybe on 1 medication. You're in good shape. You haven't had a rejection recently. So now is the time. And then you can, stop the mycophenolate and rapamycin, and make sure that if you're switching them to azathioprine, you give them a couple of months to see how well they tolerate it and get them ready. It really requires a lot of planning. I mean, I think that's something that the patient has to understand, because they can get pregnant right away. They can get pregnant 3 weeks after their transplant, and you don't want that to happen. So I think that's one message I would like to communicate. And then the second message really is that once they get pregnant, you really need to work closely with the obstetrician, with the transplant physician, sometimes the surgeon, but hopefully not the surgeon. The transplant surgeon, their work is mostly done. Occasionally there's a surgical complication, but most of the time not. And you have to follow them very closely. And, I think one of the most challenging problems could be recurrent urinary tract infections. If they're so inclined, can be a problem. So you have to stay on top of that. I think monitoring the tacrolimus level is very complicated, and, you have to, I'm going to be talking about that. There's a lot we don't know about it, but what we do know is that the levels go down in pregnancy. So if you're monitoring the levels before pregnancy, they'll be like 6, and then they get pregnant and they could go down to 4 or 3. And, you know, if you read about it in the literature, they'll tell you increase the dose. But it's not that simple. There are a lot of changes in tacrolimus metabolism during pregnancy, and you really shouldn't. Sometimes if the level gets really low, like less than 2 or 3, you might want to increase the dose. But if there are a lot of physiologic changes in pregnancy that increase the bioavailability of the tacrolimus, and so you don't want to necessarily increase the dose automatically without seeing what's happening with the patient, because if you do that, then the blood pressure will go up and the creatinine will go up, and everybody will get confused. Is the patient getting preeclampsia, or is it just too much tacrolimus on board that's not being reflected in the drug levels? So those are some of the...
That is a very, very important point, because even here what we used to practice prior was that we just switch up the tacrolimus levels, and we found that people definitely got hypertensive with that. It is something about TAC and pregnancy. It might not cause hypertension in others, but somehow in pregnancy it does. So we have also started using this now, that till the time creatinine is stable, we don't we just allow the TAC levels to be where they are. But that is a very, very important point, because especially in a country like ours, where monitoring of TAC level is also not very easily freely available. Like, it's freely available, but it's costly. Not every patient might be able to afford that. So we have to take it with a little bit pinch of salt, the levels going up and down.
Definitely. I'm willing to see the levels, you know, assuming that it's a patient who's, especially if the patient had a transplant, you know, many years ago and is stable and has good kidney function, I'm willing to see let the tacrolimus levels go down. You know, I don't like to see them go down to the low 2s, but, you know, from 4 to 2.5, I mean, sometimes I increase it a little bit if it gets too low, but I try not to, especially if the blood pressure is going up. If the blood pressure is going up, then they're probably on too much tacro.
That's a very relevant point for our patients here. And so now I want to ask you, as a early career nephrologist, that what are the avenues for a nephrologist and a transplant physician in our country? It's not separate. Nephrologists only who are doing other things also, they do transplant also. They are not only doing transplant, they're doing everything. So what are the avenues in the field of obstetric nephrology for people like me or other delegates who will be coming to our conference? What are the things which we can explore, and whether we can develop it as a niche thing for us to proceed with our careers?
I mean, I think it's a great, you know, obstetric nephrology is a great niche area for nephrologists. And I think the key is working with your obstetric team, you know, getting to know them, you know, inviting them to give conferences or in your department, like, or you talking to the, you know, your peers, especially in the high-risk obstetricians, you know, let them know that you're available to give a talk on kidney problems in obstetrics or AKI. You know, you want to give a talk about that, and so get to know them. And maybe, you know, what I used to do, be available. Like, when, you know, the obstetricians have varying, it depends on what their training is. Some of the general obstetricians don't have a lot of training in the use of blood pressure medications, and they need help. So be available. If, you know, let them know that you're available to help them, you know, prescribe blood pressure medications and deal with questions that arise if they pick up proteinuria in the middle of pregnancy, how to evaluate that. Kind of, I think that was very useful to me in my career. Is I had really good relationships with the with the obstetricians at my hospital. For example, if you're working on the AKI in pregnancy project, invite one of the OB residents or fellows to work with one of your residents together on it. It'll be a better project because they'll be able to collect some of the data that you won't have access to, you know, in terms of that. So it'll just, I think that's helpful, because otherwise, I don't know how it is in India, but in the US, otherwise, you know, they're in silos. The obstetricians are working by themselves, and then the nephrologists, and then by the, you know, a lot of my nephrology colleagues, especially the men who haven't worked in obstetric nephrology, if they get called to see a pregnant patient infrequently, when they do see that patient, they get nervous. They don't know what to do.
Yes.
What do I do? She's pregnant. What is, I mean, they don't know the language, you know what I mean? Because
Yes.
you have to, as a nephrologist, you have to learn a lot of you've got to relearn the obstetrics.
Absolutely. And that is something really lacking in our practice also. Like, we need to have a dedicated clinic where the nephrologist, the obstetrician, and maybe even the hypertension specialist might sit together and take patient decisions. So actually, we are coming
And
at the end of.
cardiologists.
Yes, ma'am.
Oh, the cardiologists also.
Yes, definitely the cardiologist. So, ma'am, we are coming at the end of this wonderful talk with you. So, I got to know that you have visited India quite a few times before, and this time you plan to see the city of Kolkata. Are you excited about? Are you going to do some sightseeing, visit some tourist places?
We hope so. We hope that we'll have some time from the meeting to see Calcutta. I've been reading a lot of books about Calcutta, novels mostly, but that take place in Calcutta. And so I've come to know more about the culture and the city itself. So I think it should be great.
Yeah, I'm sure you're going to enjoy it a lot. It's a city with a very rich traditions, and now is the time. It is a festive season. We have Durga Puja festival coming up, which is the biggest festival in Kolkata of the Bengali tradition. So I'm sure you will be enjoying a lot, and we will be looking forward to hearing more from you at ISOT 2023. Thank you so much, ma'am, for all your time. We really look forward to meeting you at Kolkata. Thanks a lot, ma'am.
Thank you. Thank you very much. It was a pleasure to meet you, and I will see you at the meeting.
Yes, sure. Thank you, ma'am.